Good evening, everyone. My name is Simiran and I welcome you all on behalf of Voice of Healthcare to an important panel discussion, Lighted Red for Blood Cancer, supported by Pfizer. We are gathered here to shed light on a topic that affects countless lives but often goes unnoticed: blood cancer. With September being Blood Cancer Awareness Month, this is a timely opportunity to raise awareness, share insights, and discuss advances in the prevention, diagnosis, and treatment of this life threatening disease. And today, for this panel discussion, we are honored to have a distinguished panel of experts who will guide us through key insights on prevention, diagnosis, treatment options, and the future of blood cancer research. So let's dive into this crucial conversation, and I would like to welcome our panelists for today's panel discussion. I would like to welcome Dr. Shouriyo Ghosh, Associate Consultant, Clinical Hematology and Cellular Therapies at Tata Medical Center, Kolkata. Welcome, Dr. Shouriyo.
Thank you very much. Thank you for this opportunity.
Thank you so much. Dr. Poojitha Byreddy, Consultant Clinical Hematology and BMT Physician at Care Hospital, Hyderabad. Good evening, Dr. Poojitha.
Thank you, Ms. Sindhi. Thank you for the opportunity.
Thank you. Dr. Abhishek Kumar Maurya, Consultant Hematology and Hemato-Oncology BMT Physician at Varanasi. Welcome to our show, Dr. Abhishek.
Thank you. Thank you for welcoming me and giving this opportunity.
Thank you. Now, I would like to welcome Dr. Rahul Arora, Consultant Hematologist and BMT Physician at Max Hospital, Nagpur. Good evening, Dr. Rahul Arora, and welcome to our show.
Thank you, Ms. Simiran and Team Pfizer, and thank you for giving me this opportunity. Thank you.
Thank you so much to all the panelists present here for this engaging panel discussion. And now I would like to start my panel discussion with Dr. Rahul Arora by understanding more about blood cancer. So, Dr. Rahul, my first question is to you. Can you briefly explain the different types of blood cancer and how do they differ in their progressions and treatment? And if we are talking about blood cancers, how prevalent is blood cancer globally in India? That and we are seeing the trends in any new trends in this incidence.
So, when we talk about blood cancer can be of various different types. And the common blood cancer we talk about are leukemia, lymphoma, and myeloma. Then leukemia is again further divided into an acute leukemia and a chronic leukemia. The acute leukemias can be further divided into an acute myeloid leukemia and acute lymphoblastic leukemia. Similarly, the chronic leukemias are divided into chronic lymphocytic leukemia and chronic myeloid leukemias. It is very important to understand that how these cancers are divided, and also because the treatment varies very differently. The If we talk about the lymphomas are again divided into an Hodgkin lymphoma and a non-Hodgkin lymphoma. The non-Hodgkin lymphomas are again divided into various different types. The common types are a diffuse large B-cell lymphoma, which is an aggressive type, and a follicular lymphoma, which is a very common lymphoma, and which is of a recurring type or a chronic type. Multiple myeloma again is an important blood cancer which originates from the plasma cells. These multiple myelomas again are divided into smoldering type and symptomatic multiple myeloma and an aggressive plasma cell leukemia. These are the common leukemias and or common blood cancers which we talk about. It is important that how we diagnose, how we treat them. We are going to discuss today. If we talk about the incidences of leukemia, we at India do not have a very large registry where we can get a lot of data. But if we talk about the data from the international registries, approximately 5 lakh cases of acute leukemia are diagnosed every year in United States. And if you talk about lymphomas, again, there are upon 5.5 lakh cases are diagnosed every year of about the chronic leukemia. If we talk about multiple myelomas, approximately 2 lakh cases, 2.2 to 2.5 lakh cases of multiple myelomas are diagnosed every year. This is every year, and this incidence is gradually increasing. The exact cause of why this leukemia or lymphomas or myelomas are increasing is not known, but probably the risk factors are also increasing. If we talk about the incidence in India, Though these numbers are very small, but approximately the last data which came is around 2022, which shows that approximately 1 lakh leukemia cases, both acute and chronic, were diagnosed in 2022. And if we talk about multiple myeloma, the ratio stands at around 50 to 60,000. But these numbers are very small compared to what the Indian population is. So this is about, in brief, about the types of leukemia and their incidences, and then we'll further talk about how we diagnose and how we evaluate these cases.
Thank you so much, Dr. Rahul, for explaining that to us and to all our audience for the basic understanding of what exactly is blood cancer. And now, moving on, I would like to ask from Dr. Poojitha, can you please tell us about causes and risk factors? So, what are the known risk factors for developing blood cancer? And are there any environmental or genetic predispositions that patients should be aware of?
Yeah, thank
Thank
you
you.
for that question. Uh, as we all know that there are, yeah, hello, is it audible?
Yes, yes, we can hear you.
Hello, yeah, yeah, yes, Imran. Thank you for that question. So regarding the risk factors, each separate entity of the above listed leukemia lymphomas have particular different kinds of risk factors. It will be enumerable. So if we generally speaking, these cancers increase with the age. So as the person ages, so there is increase in the incidence and increase in this detection of these cancers. Apart from the age as a main risk factor, there are certain environmental risk factors to be considered, like exposure to any toxic therapy. Like if the patient had any previous chemotherapy for any other secondary solid cancer or any other thing, then these chemotherapies will initiate certain genetical damage in our body at the cellular level. So this will initiate the process of leukemia genesis. So that is one another risk factor for initiating the blood cancers. And the next common one or next well studied risk factor is the radiation therapy. We all know that during the World War II, where the people were exposed to the radiation therapy, or during the nuclear accidents like in Chernobyl nuclear accident, the people who were exposed to this radiation, high intensity radiation, were more prone to develop leukemia. So age, any previous exposure to the chemotherapy, radiation therapy, or any chronic infections in the form of EBV is a viral infection which can initiate lymphoproliferative disorders, or hepatitis B infection can also cause low-grade lymphoproliferative disorders. And the common most bacterial infection like H. pylori infection can initiate maltomas, that is stomach-based cancers. And apart from this, we do know that HIV is a very the people who have HIV are more prone for blood cancers. So these kind of viral infections, bacterial infections can also cause the increase in the risk of leukemia. And one more new entity which is in becoming which is being studied and which people are interested nowadays is inflammaging. Inflammaging is any inflammatory disorder which is present chronically in a person, for suppose any tuberculosis infection or any rheumatological disorder or any autoimmune disorder which is present for a long time, will initiate certain genetical changes in our cells which will further lead to the progression into the cancers. So these will develop as a pre myelodysplastic syndrome states, and then progress to MDS, and then they can progress to AML. So these are the environmental and general risk factors. If you look into the genetic predisposition, there are certain syndromes definitely. For suppose in case of Hodgkin lymphomas or any lymphomas, there is a small incidence increase in the incidence of lymphomas if there is a genetical if it is running in the family. Apart from this, there are certain germline mutations which will lead to increase in the incidence of AML, like Lee Frommeni syndrome, where TP53 mutation is noted, or any RB gene mutations which are running in the family, or any other known germline mutations are there, like RADX1, GATA2, or Fanconi anemias. All of these are genetic mutations which can lead to the AML. So we discussed basically the environmental risk factors as well as the genetic risk factors. But if you look into the incidence, commonly the environmental risk factors are more common than the genetical risk factors. Thank you.
Thank you so much for so elaboratively explaining that to us. My follow-up question on that: can lifestyle changes or preventive measure can reduce the risk of developing such blood cancers?
Yeah, coming to that, as I mentioned, one new entity is inflammation. So, any patient who is obese or who has chronic type 2 diabetes or who has chronic smoking history, chronic alcohol history, these patients are known to develop pre-malignant states. So if we can alter the lifestyle, if we can inculcate more good health habits like exercise regularly, take a healthy diet, maybe these pre-malignant states can be reduced, and thus it can help in reducing the burden of the malignancy. But it's not well studied. I mean, we don't know effective data how much decrease in the incidence will be there if we alter the lifestyle. But yeah, theoretically, it is possible that if we alter the lifestyle, there can be decrease in the incidence of the pre-malignant states.
Thank you for that, Dr. Poojitha. Moving on to my next question to understand another very important aspect of that is early warning signs. So I would like to ask Dr. Abhishek, what are the most common signs and symptoms of blood cancer that individuals should watch for to ensure timely diagnosis?
Yes, thank you. Thank you for the question. It is a nice question because the people are who are around us, they are not very curious, and after knowing the exact early sign or symptom, they will curious. And because the awareness before people, when they are not aware that the what are the warning signs, after that they go to the hematologist or the oncologist for that. No, so the most common sign and symptoms we see in our daily routine, that patient complaining of unexplained weight loss, significant weight loss. That means the loss of weight of 10% within a 6 month of period, drenching night sweat, unexplained fever. These are the mostly they go towards the lymphoma, any type of lymphoma. And then patient normally explaining or the complaining of the multiple rashes or the bleeding from gums, bleeding from cough, or the blood vomiters, or comes with the hematuria. uh, and many hemorrhagic symptoms are there. But mostly patient of lymphoma, either we include the both type of the cancer in blood cancer, either it is lymphoma or leukemia. Mainly patient with lymphoma comes with the generalized lymphadenopathy or splenomegaly, and patient complaining of the splenomegaly with dragging sensation, dragging pain, or the early satiety. And this type of the early symptoms of the leukemia or the lymphoma, and patients should go to the hematologist for this type of the symptom. Thank you.
Thank you so much for that. And another follow-up question on this is, since blood cancer symptoms are often overlapped with other less serious conditions, so how can patient and doctor, so patients can differentiate between them?
Yeah, this is a good question. Nice. The people who, as it can be understood by an example, that patient comes with the high TLC, and with high TLC, patient coming whether it is leukemia or the leukemioid reaction. Then for that we have go through the CBC, bone marrow examinations, or some cytochemical test for that to uh, to differentiate whether it is leukemia or only a leukemioid reaction. After that, many lymphocytes in the CBC blood smear are the reactive lymphocytes or may look as a blast. So we have to differentiate between the blast, or these are the reactive lymphocytes. We have to go for the flow cytometry or the bone marrow biopsy, and further for ISC. And these are the some tests, and also the imaging test, like we have to go for the PET scan, whether they are the lymph nodes which are going to be developed in our retroperitoneal lymph nodes, or the other lymph nodes which are going, whether they are reactive lymphadenopathy or they are having some SUV max go through the maximum times, and they are the malignant one. Then these are some imaging or the blood test which are going to differentiate between whether they are reactive or they are malignant. Thank you.
So to find out further, patients have, or the person who's having those symptoms, they definitely have to go to the doctor first, and then only it can be classified what exactly it is. So here we want to emphasize on early diagnosis and going to the doctors for as early possible for the checkups. So moving on, since we're talking about early signs and diagnosis, I want to talk to Dr. Shaurya regarding delay in diagnosis. So, what are some of the common reasons for delays in diagnosis of blood cancer? And how can patient and healthcare providers work together to avoid these kind of delays?
Right, thank you. So, as Dr. Abhishek rightly pointed out, there are so many signs and symptoms which are overlapping with other non malignant conditions. So, common causes for delay is primarily a misdiagnosis, or even before that, some patients might have very non-specific symptoms like generalized fatigue or weight loss, which goes unnoticed. So, here I would like to say that the acute leukemias, as it was pointed out earlier in the talk, acute leukemias are usually quite dramatic in presentation. There will be, the patient will be quite sick. The patient will have, bleeding from various sites in the body. The patient might have, high-grade fevers, and the patient usually presents to us pretty fast. The lymphoma sometimes might get misdiagnosed as lymphomas presenting as lumps, or lumps in the neck or lumps in any other part of the body, might get misdiagnosed as tuberculosis, and might have had a course of anti-tubercular treatment before they come to us. Patients sometimes might present just with thrombocytopenia, that is low platelets, and somebody might misdiagnose as immune thrombocytopenia, or just pass it off as maybe a viral infection eventually, and treat with steroids. That is a common presentation, not very common, but we have seen sometimes that such patients turn up to have leukemia later on. So the other thing is proximity to healthcare centers. Now, as we know, our lot of patients don't have ready access. The people who don't live in cities, but the people who live, let's say, in remote areas, or in places where you don't have ready access to a hematologist or to a tertiary care center. In those people also, sometimes there is a delay in diagnosis. The uh, so these are more few of the common causes in which the diagnosis may be delayed or missed. Myelomas can sometimes be diagnosed pretty late because the presentation might be just low back pain. So a patient may be disregarding the symptom for a few months together, thinking that it may be just a benign thing. It's a low back pain that can happen to anybody, but eventually, that patient develops a fracture or something and then comes to the hospital. Another situation where sometimes myelomas with predominantly kidney involvement may be missed is where a patient already has diabetes or has been having some elevated creatinine values, goes to a nephrologist, and it is somehow it is missed that the patient has a myeloma, but it has been missed, and it takes maybe a few more months before the nephrologist actually sends the patient to us saying that yes, this could be a disorder of the plasma cells, which is causing elevation in creatinine. So these are the situations in which diagnosis might be delayed.
Thank you so much, Dr. Shaurya, for explaining that to us. On that note, I would just like to ask a follow-up question. Like, we know there's further reasons of delay in diagnosis, which you just explained to us, as people are not much aware of it. So, in your experience, what do you felt, how do you felt that what all public awareness campaigns can help in educating people to seek medical attention early when they experience these related symptoms to it?
Yeah, so we regularly have awareness programs and camps in the hospital, in not camps but awareness programs, in which cancer survivors and people who have been treated with cancer reach out and reach out to their communities and kind of spread the message that yes, these I mean, some of these are treatable cancer, some of these can be permanently cured, so better to go to the right doctor at the right time to get a timely diagnosis and treatment. So that helps. So patients themselves move the awareness forward. That is one thing. The other is, I think, definitely media has a role to play, in which if you have like awareness sort of clips or bytes in which you share information like this, especially on World Lymphoma Awareness Day or World Lymphoma Day or things like that, in which I think the pickup rate will increase, especially for a country such as so vast as us.
Thank you for giving your insights on that question. Moving on to my next question, or next important part, that is screening and diagnosis of blood cancer. Dr. Rahul, I would like to know: are there established screening guidelines for blood cancer in the general population, or are screenings typically performed for high risk individuals only?
So if we talk about the screening method in general population, there is no particular guideline which says that we should screen all the patients for a specific type of blood cancer. But there has been data for multiple myeloma where general screening population have been screened and found to have MGUS or a smoldering multiple myeloma, where they were followed up and found to have a 3% risk of 1 to 3% of risk of developing symptomatic multiple myeloma. But for acute leukemia and chronic leukemia, we do not have a screening for general population. But yes, for a certain subset of high risk patients, like explained earlier about the risk of developing a cancer in certain patients who have already received a certain form of a chemotherapy for solid cancer, they are at a risk of developing cancer, blood cancers, and they should be screened regularly for blood cancer so that they can be detected early and treated early. Similarly, for certain genetic risk factors, like people of having a family history of blood cancer or a family history of certain genetic disorders like Fanconi anemia or certain bone marrow failure syndromes or certain platelet-related genetic disorders, these patients should be screened for regular blood test, and if found to have certain cytopenias, certain blood cells which are on a lower side, developing anemia or developing high or low WBC, and their peripheral smear should be screened, and then these high risk populations should be further subjected to bone marrow test if required uh, for evaluation of developing a leukemia or lymphoma. Similarly, if you want to evaluate further, what tests are needed to diagnose further? So we need a bone marrow test, aspiration, and a biopsy. And further, we require a immunophenotyping either by a flow cytometry or a detailed IFC for evaluation of what type of blood cancer that the patient has developed. For characterization of leukemia or lymphoma, we sometimes require a PET-CT scan, especially for a lymphoma, where PET-CT can help us guide us through the stage of lymphoma, and also for evaluating the response assessment in certain forms of lymphoma. Uh, Similarly, for multiple myeloma, there is a comprehensive multiple myeloma panel which has been specifically designed to evaluate a plasma cell disorder. And this multiple myeloma panel or a plasma cell protein panel can help us in diagnosing what type of multiple myeloma it is, whether it is IgG, kappa, M protein, what type of immunoglobulin it is IgG, IgA, or IgM, and we also need to evaluate for certain type of multiple myeloma where these proteins are negative and the light chains are positive. We call them as light chain myeloma, and sometimes this is also earlier was missed and was maybe a diagnosis, maybe the diagnosis were delayed because these were light chain myeloma. These were missed if we only do a serum protein electrophoresis where only M proteins are detected, and these light chains are missed. So in short, we do not have a generalized guidelines for evaluation of screening of leukemia lymphoma. As we have for lung cancer or a colon cancer, we have screening methods, or the stomach cancer. But for general population, we cannot screen them. The preventive health checkups, in during preventive health checkups, we do find sometimes patients suffering from chronic leukemias, but usually acute leukemia, as discussed earlier, is so acute and so symptomatic that they may not be picked up during the routine evaluations. And for specific type of screening, we evaluate high risk population, and we need sometimes a detailed evaluation once we found a suspicion for a particular type of a cancer. Thank you.
And since we're talking about screening and diagnosis, and you mentioned about the preventive checkups, so what role does blood test, bone marrow biopsies, and genetic testing play in early detection of blood cancer? Those who are having this acute blood cancer, and they're not, the symptoms are so normal that it is not easy to detect, right? You just mentioned about it.
So the most important test we talk about in hematology is a CBC and a peripheral smear. So once we do this test and we found certain abnormalities, then further evaluation needs to be done. And if possible, needs to be done at a center which is experienced enough to evaluate a certain kind of blood cancers. So their complete evaluation needs to be done. If we are evaluating a cancer, specifically a blood related cancer, which requires a thorough workup, because in the first visit itself all the investigations which are needed needs to be done. Otherwise the prognosis and the diagnostic workup might be missed, and it creates challenge later when we plan a treatment protocol for certain type of a cancer, blood cancer. The upfront evaluation is important. So if we miss those upfront evaluation, the staging workup or the further treatment planning gets affected. Because if we miss the genetic diagnosis of today, the diagnosis of AML, if, for example, cannot be made without an NGS testing. So NGS testing today plays a very important role in AML and an ALL treatment, because the treatment protocols or these targeted treatment depends on the type of genetic mutations we are getting, and we are getting more and more targeted therapy for these type of subtype of cancer, where even an AML is not one disease. AML itself becomes a disease with various genetic mutations, and specific mutation needs to be evaluated while we talk about those cancers. So that is why it is very requires a thorough evaluation and further workup.
Thank you so much, Dr. Rahul, for shedding light on that. Now, I would like to ask Dr. Poojitha for the advances in diagnostics. So, Dr. Poojitha, how are new diagnostic tools like molecular testing and genomic profiling changing the blood cancers that diagnosed and treated?
Yeah, thank you for that question, Ms. Simran. So, as Dr. Rahul Arora sir has mentioned elaboratively, based on uh, on multiple sets of investigations, we do work up in the patients with suspected leukemia or any blood cancer per se. So, these tests have now helped us to very confirmatively differentiate and diagnose these tests. For example, previously, the chronic myeloid leukemias, like suppose 30, 40 years before, we had only PCR based sequencing tests where we used to look into the tyrosine kinase mutation analysis, and based on that we used to treat them. But because these tests have come into vogue, or these tests are easily available now, these tests are being used now not only for the diagnosis as well as for the monitoring of the disease status also. That is one important help which these tests are currently being used. And if we look into these tests, suppose, as Sir mentioned, the NGS test is very important now for the workup of the leukemias, because previously we used to just rely on morphological diagnosis, where the percentage number of the blasts, like more than 20%, was used as a qualifier to differentiate the patient into an MDS or as such into acute leukemia. But now with the genomic profiling or the NGS based analysis, even a particular AML related mutation, if it is present, the quantifier which we used to diagnose the patient before has come, we are not using that frequently now, because if these mutations are present, even with the 10% blast, even sometimes if they're a very high risk patient, they are mentioning that if the presence of these mutation itself is enough to diagnose a patient with the AML. So the morphological or the role of the morphology still is present. I don't say that morphology is not required. It is very important, but the genomic profiling and the NGS, the molecular testing has become very important. So that is one role. So differentiate and to confirm the presence of the cancer, type of cancer. Next, coming to the second important thing is these genomic profiling or the molecular testing is helpful in the monitoring of the disease also. For example, in CML, I have mentioned the BCR ABL mutation which is present. We will use it as a monitoring marker also, so that we quantify this marker, and at a particular time points in the duration of the therapy, based on these markers, we label the patient whether he has responded optimally or whether there is any failure in the response as per se. And next, coming to the in case of acute leukemias. So acute leukemias require high intensity therapy, and after the therapy, we do bone marrow testing to see whether the patient has went into remission or not. Not just the morphological criteria are presently being used. We are also using the molecular markers now. That is minimal residual disease, which is labeled in abbreviated as MRD. These MRD based tests are highly helpful in quantifying the disease, whether it is present or whether we have achieved that deeper molecular remission rates in the patients, which is translated into a increase, I mean, in increasing the overall survival or decreasing the relapse rates in these patients.
Thank you, Dr. Poojitha, for elaboratively explaining us about the molecular testing and genomic profiling. It is very helpful to understand how these new diagnostic tools are working in case of blood cancer. But are there any further advancements that we can expect in blood cancer screening and diagnosis in near future in our country?
Definitely, NGS is one thing, and next one in the these are all comes under the second and third generation, and the next generation molecular tests or the nanopore tests or the single cell analysis or the liquid biopsy analysis, where the cells are studied at a single cell level. So these tests will help us in further analyzing the molecular profile of the cancer, as well as for the further stringent monitoring of the disease. Not just that, and based on these analysis, various targeted therapies are being designed, and each and if you look into the previously, we thought that the leukemias or any lymphomas are caused by a single mutation, but now we are saying that it is a clone. Each the leukemia or myelomas can have various clones, and each clone can be present even and different clones can be present at a relapse or in the baseline settings. So these tests which I have mentioned, like single nanopore testing or single cellular liquid based analysis, will help in further analyzing the disease and also for monitoring the disease.
Thank you, Dr. Poojitha, for that. Moving on to my next section, that is living with blood cancers and patient care, which is another important aspect regarding in terms of the people or the patients who are actually living with a blood cancer. So I would like to ask Dr. Abhishek Kumar, if you can explain how does living with blood cancer affects a patient's physical and emotional well-being, and what are the most significant challenges they face during their treatment, as we just discussed about the blood cancer early signs and symptoms diagnosis and the advanced testing. So now I would like to hear different perspective on this.
Yes, thank you. Uh, Before we go, I go to the answer of this question. I would like to differentiate the cancer patient into adult patient or the pediatric patient. because we all see in in the leukemia ward of the mostly the pediatric patient, the age of the child is like 3 years, 2 years, 5 year old, and this is the time. This is the time when the normal child has the happy moments, like they used to play with their father, mother, elder sister, or brother. And now, when the patient or the pediatric patient, that child diagnosed with the leukemia like AML, ALL, or whatever it is, then patient have to admit in the hospital for induction therapy, usually more than a month. For 1 month, patient have to stay in the hospital, and with this, patient lost all his gaming or the playing, and the patient of this type of the age have many more things to do, like they want to go outside or they want to play with many more children or in groups. But we but this type of the patient has to be the in a single room or in a single ward, and they have to spend their 1 month, or not only 1 month for the induction, also they have the consolidation phase or for maintenance phase, or after giving the chemotherapy, patient has many more side effects for that. And for this, patient has come in between for treatment of febrile neutropenia, or whether patient have many more side effects of this chemotherapy, and whole of the time of the childhood going to the hospital, hospital to home, home to hospital. Patient have the child have no any school life, no any the other side of the life, and the playing in the grounds, because we have to restrict them to play with the other people or play in the, because there is a risk of infection, na? So that's why. And the whole time of the during the chemotherapy time, the patient go into the, and this causes also the major trauma to that patient, not only that patient, their family only, their family also affected by that. And in the adult, for an example, if a person aging of the 30 or 35-year old, and he diagnosed with the AML, then this is the very bigger mental trauma for this family, because he is the only person who is the he is the only person who have the job, and who is basically the earning person of that family. Then then the family, whole of the family suffer for that, because the earning person admitted to the hospital, and all family which are depending on that person only, they have very grievous mental trauma for that the family. So this is the, I personally saw that whether there is pediatric patient or whether there is the adult patient in the leukemia or the lymphoma or any type of the blood cancer, the family, for emotionally, financially, socially, they were tired of that, and I saw that. Thank you.
Thank you so much for explaining that to us. And yes, you said it right. Whenever a person is diagnosed with, let's say, blood cancer or any other type of cancer, it does not affect that person only. It affects their family, emotionally, mentally, financially, in every aspect. But then we have our doctors out there to help them out, to give them a proper care. And nowadays, we also have that uh, patient support system. So I would like to ask a follow-up question on that. So what role do support system, both medically and familial, play in helping patients to cope up with these kind of diseases?
Yes. Uh, First of all, I will go to the familial support with an example that many of the chemotherapy, after getting chemotherapy, there is a side effect. This is loss of hair.
Hmm.
So during my DM period, one family, mother and father, both have to cut their hair to support the his child with this mental support, that we are also bald, you also bald. So that makes the child a little happy, that not only me as a loss of hair on all the my family also have my father, mother, this type of thing, and the medical support, which is very important, because the chemotherapy, as we all know, many chemotherapies are out of the pocket of many of the middle class family. So many NGOs are behind this, who are getting this type of the chemotherapy for the cancer people, and in cancer people, and they provide the diagnostic also and the cost of the chemotherapy free of cost to the patient of the leukemia. And I think this type of NGO should come forward and help this type of the people of the blood cancer.
You gave us a very strong example, a very good example of a very strong family. Those parents has
Yes.
also cut their hair to support their child, and it does not feel that only I do not have that hairs. My parents are also there in this fight. So yes, I think we do have such very great examples out there. So moving on to the role of patient advocacy, sorry, a long-term survivorship. Dr. Shaurya, I would like to know for those living with chronic forms of blood cancer, what are the key aspects of long term management and how does it impact their daily lives?
Right. So this is also a very important question. So I'll try to break it down into two parts. So there are some cancers which are chronic cancers in the sense that you will require treatment to go on for a long period of time. And there are some blood cancers where there is an initial treatment followed by, let's say, a period of follow up in which the patient might do well, or the patient or the disease might come back. Right. So let's take the first instance in which there's a disease called chronic myeloid leukemia. So, chronic myeloid leukemia is something where the life expectancy with the current treatment of modern treatment of CML, the life expectancy is the same as that of a normal individual. So, this is what I tell my patients when they are diagnosed with CML on day one. So I say that don't worry, you have a disease which technically is a cancer, but with proper treatment, the life expectancy is that of your neighbor, or for that matter, any random person of that age. So this is possible because of the very good treatments that are available. At the same time, CML is one unique disease in which, after a few years of treatment, and if the patient meets certain criteria, we can even stop the medication, and a considerable number of patients can maintain the disease in remission. That is, they're technically cured. So this is for that particular disease. Let's take any other blood cancer in which you have, let's say the patient has been treated with a very high dose of chemotherapy or heavy dose of chemotherapy for a long period of time. So after that, there are some long-term effects on various organ systems. So, for example, you can have chronic cardiac problems later on. You can have lung problems later on. You can have fertility issues, especially for adolescents who have been treated, and let's say somebody who has undergone a bone marrow transplant. So you can have fertility issues, right? So these things are manageable. So let's say somebody who's cured to have a bone marrow transplant, we offer fertility preservation in the form of semen or ovum cryopreservation, where you can preserve the fertility in the form of banking the sperm or the eggs, and then later on, after the patient is completely cured later on in life, he or she can go in and have in vitro or a test tube baby as we know it. For cardiac and lung complications, we regularly monitor these patients for, by doing basic screening, echocardiograms or pulmonary function tests to make sure that these patients are not developing chronic pulmonary or cardiac problems. Patients in a certain situation post transplant, patients can have cognitive effects or learning disabilities. This especially happens with pediatric patients undergoing radiation to the brain. So nowadays treatments have improved to an extent that we are trying to cut down on the dose of radiation to the brain and do different treatment approaches so that these learning disabilities don't happen. So this is one thing. This is one aspect of it. of long-term survivorship. Then there are other newer treatments coming up in hematology, like CAR T cell treatment and all. These also have a lot of long-term complications and long-term adverse events. So those are, it's kind of a work in progress, but there are ways and means of addressing these issues and overcoming them. The other thing is that uh, support groups. So in our hospital, for example, we usually have survivor meets. So these address the emotional and psychological aspects. So when patients come back and see, when patients undergoing treatment, they come and attend such survivor meets, they get a big boost in their confidence. They feel that yes, so there are patients who have been completely cured, they are leading normal lives. So the emotional and psychological aspects are taken care of with these support groups and these survivor meets that we have for each disease. So we have separate for lymphoma, for myeloma, for CML, etc. And the other thing is, like, we do share success stories. Like, you treat a child with leukemia, the child is cured, the child comes back, 10 years later, 12 years later, uh, and says that I have done my, class 12 exams, I have scored such high marks, now I want to be a doctor. So those are success stories, and we have, success stories in the sense, in the form of, one of our colleagues who is now the HOD of a leading institute in the country, who is a lymphoma survivor. So there are success stories like that. There are success stories in which patients have battled a lot of battled cancers or very refractory lymphomas, leukemias, undergone transplants, and now having absolutely normal lives. So those are things which, give us hope and give other patients hope as well.
And I think that is very important, a part of like treatment. We have a advanced treatment options and plans available. So I think this is a very important part of the treatment aspect only, because when a patient who is suffering from such deadly, or let's say blood cancer, and when they need those survivors who have faced that, challenged it, and have overcome it and living their life fully, so this gives them another hope, and a positive approach,
Absolutely.
and the treatment also works 100%ly, it with full
Absolutely.
efficacy, because the
Yes.
patient is also ready to receive it, and with the hope of living and to
Yes.
fight this deadly disease. So I think these kinds of meet
So
and greets,
yes.
or campaigns is very important for the
Right.
patients.
So my mantra in my clinic is to motivate the patient. Of course, there are certain cancers which are really quite difficult to manage, or have, not so good outcomes. Cancers within hematology. So all said and done, majority of the lymphomas are treatable even in advanced stages. Majority of the myelomas with good treatment can be controlled very well. Pediatric leukemias are, do have a very good survival outcome. So there are, it's not always all gloomy, and it's not that all cancers are bad. All blood cancers are bad, and no, there is no hope. So this is not the right way to look at it. So we should have a positive approach when we are dealing with our patients.
We definitely should have a positive approach, and to bring that, or to maintain that positivity, we have patient advocacy groups. So I would like to know from Dr. Rahul, like Dr. Shourya mentioned about few of the NGOs and few of the campaigns in which this meet and greets kind of things keep on happening with the patients. So how can patient advocacy groups and healthcare providers better support those living with blood cancer in terms of access of treatment, clinical trials, and emotional support, in your view?
So a very good question, and a question which requires most of your attention in our practice today. So when we are talking about patient advocacy and the role of a healthcare in different types of leukemia and lymphoma, because all these lymphoma survivors have different queries, and once they are diagnosed as a case of a leukemia or lymphoma or a myeloma, they have lot of questions, they have lot of queries, and they are in a state of shock sometimes when we break the news to them. So there, this support system is required. There, this patient advocacy or support group can really help them overcome their fears about their treatment, about their diagnosis, and also this support group can also sometimes help financially to the people who cannot afford some certain kind of diagnosis or treatment. So all said and done, we are a little lacking in this patient advocacy, where we see like in hematology per se, we have a lot of support group in sickle cell support group and thalassemia support group. However, in blood cancer, we are little behind, and we need to step forward in making more and more of these support group at different levels at a town level, at a state level, and at a national level, where we can give different kind of support to people of different strata and different people coming from different parts of India. And this can really help in making healthcare decisions about the funds which the government can really uh, different disorders, how they are managed, because with newer and newer treatment, the costing of treatment is increasing, because more and more refined treatment getting to these disorders. And with patient advocacy, it can really narrow down where the focus of government funding can be. They can help us in finding out where, with the available funds, how it can reach to the larger population, uh, and try to treat most of these patients with government support. Certain kind of funding is available at the moment with the Prime Minister Fund and a Chief Minister Fund, where they can really help us in making a patient go through a transplant. And the patient support group really can help us in providing the voice of these patients uh, at a national level and at a state level as well, where the policies can be designed for making this blood cancer really treatable and approachable. And patients should not fear about because now we see that many patients, when diagnosed with a blood cancer, they say this is the end of the road for them. But if
Yes.
this support system, if this fund channelizing is there, if patient advocacy support is there, if they have proper information about the disorder, if they have, we have been providing them awareness about disorders, then this can really make changes. And it is very important that all the patients who are diagnosed are treated. Nowadays, we see a lot of patients are not getting even to the diagnosis. Getting to a diagnosis was a challenge. If that challenge is overcome, then taking these patients to a treatment is a challenge. So these support group can really help there to give treatment to multiple to give treatment to as many patients as possible and as much as possible, so that these patients can be cured, and their desire to live more and live a content life is.
You mentioned this very rightly, Dr. Rahul, that this patient advocacy groups works in a very positive direction, where actually it can raise their voices to reach to the authorities, and they can get to know what exactly and where do these funds are required. Those who require that transplants, exact funds for the treatment, and they really do not have that kind of access or support for this. So this is a very great way that our healthcare system reaches to everywhere who actually needs it. And there's urgent need to, like you started with, this is a very important aspect in terms of treatment as of now required in our country, as much as patient advocacy can be done, and our healthcare system will reach there. So thank you for explaining that. And moving on to my next question to Dr.
And
Poojitha.
this webinar itself is a way where we are approaching them, and is forming a patient support.
Yes, we are.
Thank Pfizer for this,
Thank you,
and
thank
the
you.
whole team for it.
Yes, even we look forward for all such kind of sessions where we can spread more and more awareness. So moving on to Dr. Poojitha on access to care and treatment innovations. So, Dr. Poojitha, I would like to know what are the current barriers to accessing advanced blood cancer treatments, especially in developing countries like India.
Yeah. Coming to this question, I think most of the answer has been discussed already by the discussion. And we do know that the one and foremost most important barrier in developing country like India is the financial constraints. So most of the patients have financial constraint. Nearly only around 10 to 20% of the patients are having their own personal private insurance, and the BPL below poverty line patients have certain government or national government aided funds. But if you look into the majority of the chunk of the Indian population, that is the lower upper middle class or the lower middle class, they don't have the funds or they don't have the money luxury also to reach these advanced therapies. I think this is the first and the most important barrier for the approaching the therapy to the any patient in India. And the next most important barrier is the stigma associated with the cancer as such. And and the third most important is the lack of awareness. So most of the patients are, for suppose, in the tribal community where they are far away from the metros or even from the two tier towns. They don't even have the access to the basic blood counts or basic blood transfusions or any medicine. So this is another important barrier. I mean, it has improved over the years, but still there is a lot of room to improve in this aspect.
Thank you so much, Dr. Poojitha, for briefly explaining that to us. Moving on to my next question, Dr. Abhishek. Dr. Abhishek, I just want to know what are some of the recent breakthroughs in blood cancer treatment, such as targeted therapies and immunotherapies, and how they have transformed patient outcomes. We have already discussed this from Dr. Poojitha, a brief about what the future advancements, but I would like to know your views on that as well.
Yeah. Uh, Today, more and more advancements are going on for the blood cancer treatment. But recently, the hot topic is the CAR T cell therapy. I think
Yes.
after bone marrow transplant, the CAR T cell therapy is the most hot topic in the blood cancer today. In CAR T cell therapy, I briefly described. In CAR T cell therapy, we get the T cell of the patient, and that T cell is engaged with a CAR, means chimeric antigen receptor, and this CAR T cell then reinfused into that patient, and this modified T cell, that is now CAR T cell, is now act on the cancer cells. This is the basic principle of the CAR T cell, and this CAR T cell now very most important and mostly, but the cost, yeah, the cost is so high, and this is not available everywhere in some except some metro cities. But surely this will be the most important and the future of the blood cancer treatment. And some institutes also they do the CAR T cell therapy, and mostly they are going for the multiple myeloma or the lymphoma or the B cell ALL, the CAR T cell therapy, for that, for the multiple myeloma BCMA, targeting the BCMA. And second one is the bite cells, B cell, bite cells, that are the bispecific T cell engagers like blinatumomab in the ALL therapy, and recently molecule that is the nilarabin, that is for the T cell ALL or TLBL. These are the some advancements, and also immunotherapy like checkpoint inhibitors, pembrolizumab, nivolumab, for the relapse setting of the lymphoma. These are some the advancements in the blood cancer, and surely they are helpful, and they are helpful for that. Thank you.
Thank you, Dr. Abhishek, for explaining us about the advanced treatments options available. Now, I would like to ask my last question of this discussion to Dr. Shouriyo. Dr. Shouriyo, can you explain us the holistic care approach for blood cancer patients? How important is multidisciplinary approach, that is oncologist, hematologist, psychologist, etc., in the comprehensive treatment and support of blood cancer patients?
Right. This is a very important aspect, and I am fortunate to work in a hospital which is dedicated to only cancer care. So here we have an established framework in which we have we have the clinical team, which is us. We have a robust lab where everything is done in house. We don't have to send any samples outside. We also have an state of the art molecular cytogenetic diagnosis, etc. At the same time, for patient support, there are psycho-oncologists who are psychiatrists and psychological counselors who help the patient and their family, go through this difficult time. So we regularly refer our patients to them, just to talk, because we are looking at the clinical aspects, which maybe, you have this, we have to give you chemo, etc., and we will treat you. What about the emotional health? What about the psychological health? What about, some patients can have, feeling of hopelessness, doom. So just to talk to them, just to, just for them to share, or just, have just to vent, basically. You need somebody, so that we have a very good team of psycho-oncologists and counselors who do that. Then we have a very good financial assistance team, in which there are NGOs, there are fundraising support groups, there are people who help, like the previous panelists we all discussed, right, about how to arrange funds. So guiding the patients through this period, getting funds from various sources, so that they can at least complete the treatment. Then we also need nutritionists and clinical nutritionists, not just dietitians, but really experienced nutritionists who are specially trained in the nutrition needs of cancer patients. So this is very important, so that they can continue the treatment, and at the same time, maintain their health, because it's extremely difficult to have proper adequate nutrition when you are bombarding the patients with chemotherapy. Then the last but not the least is palliative treatment, where some cancers at the end of the day win, and in those situations, to help the patient pass comfortably, we have a very good palliative care team, where they specialize in keeping the patient comfortable, and also the family. So bereavement counseling, keeping the patient comfortable, where just symptom management is done. So that is also an extremely difficult task, and it's a skillful task, which many of us, when we are treating the patient aggressively, don't do that well. In that situation, the palliative team is involved, and they take over, and they basically help the patient pass in dignity and in comfort. So definitely, it's a holistic team which is required, and that is, in a nutshell, cancer care.
Thank you so much, Dr. Shaurya, for explaining us about the importance and what all is included into this holistic care for blood cancer patient, and how important is the small aspects, like you just mentioned, about the nutritionist, financial assistance, and all in each every aspects which helps patient treatment to go smoothly, and it gives a complete support to them. And I would like to thank all the panelists today present here for this panel discussion, for being part of this engaging discussion. And because of you, we could able to spread our word on blood cancer awareness. And we aim as much as awareness we can spread together for this important issue, focusing on the month of blood cancer awareness. I would like to thank you all present here for giving your time, sharing your expertise and insights with us on this panel discussion.
Thank you so much.
Thank you.
Thanks.
Thank you,
Thanks a
Simran,
lot.
and the higher oncology team. Thank you so much.
Thank you so much, and thanks a lot for this amazing discussion. Thank you.